البث المباشر ابتدأ. تفضل دكتور.
بسم الله الرحمن الرحيم والصلاة والسلام على أشرف المرسلين. السلام عليكم ورحمة الله تعالى وبركاته. My name is Dr. Ezzeldin Saleh. I am an assistant professor at SIU, Southern Illinois University in Springfield, Illinois. Thank you very much for allowing me the opportunity to talk to you guys about COVID-19 MISS, and thanks for the organizers, Dr. Nuha, Dr. Batul, and the organizer at the Sudan end. We'll start the presentation shortly, inshallah, after everything is set up. Thank you, Nuha.
تفضل يا دكتور.
شكرا. السلام عليكم ورحمة الله تعالى وبركاته. Once again, my name is Ezzeldin Saleh. I'm an assistant professor in pediatric infectious diseases at SIU. I'll be honored to talk to you again today about COVID-19 pediatric perspective. We'll be talking about the new emerging syndrome, multisystem inflammatory syndrome in children associated with COVID-19. Next slide. This will be the outline of my talk. We'll talk introduction about the pandemic, and then the COVID-19 in children and adolescents, and then about the new pediatric multisystem inflammatory syndrome, and then about association with COVID-19, and then talk about Kawasaki disease shock and compared to MIS-C shock, and then evaluation on a minimum of this syndrome, and then we'll conclude in a summary. The COVID-19 pandemic, as you all know, cases started in late December in a cluster of pneumonia of unknown origin, reported in Wuhan, China, in the province of in Wuhan city in China. Shortly after that, a novel RNA SARS-CoV-2 virus was identified as the cause, and WHO declared a COVID-19 pandemic, a health emergency worldwide. And from that, things has been unraveling. Next slide. As of yesterday, these are the numbers. For example, in the US, there are more than 2 million cases reported so far, with over 100,000 deaths. And in Sudan, almost 7,000 cases so far, with more than 400 deaths. Next slide. Through all this pandemic, children were luckily remained less affected by the COVID-19, and there's a lot of speculation why children were not affected, and still a lot of studies going on. but mainly most of the pediatric cases were very mild and asymptomatic compared to adult population. Next slide. The first pediatric reported case was from Shenzhen city in China, in a family that traveled to Wuhan. There have two kids in the family. One is 10 years old and the other one was 7. And they reported that the 10-year-old was not abiding to his parents' instructions. He wasn't using his mask, and he got infected. His PCR was positive. However, he was asymptomatic, and the CT chest showed ground glass opacities, and all his lab work otherwise was within normal limits, and he was again asymptomatic. But this case also proved the familial transmission, person-to-person transmission within family. I think after that, shortly, they were reported of severe cases in China with pediatric kids admitted to the ICU. But overall, the number of pediatrics were very, very small compared to adults. Next. Next slide now. There were, over the last couple of months, that there is a lot of literature emerging. From initially, all the cases from China reported that, again, most of the cases were very mild. And this paper reported about more than 2,000 cases from January to February. And as you see, more than 90% of the children were asymptomatic or have mild or moderate cases, and only one child reported to die. And the severe critical cases were about only less than 6% compared to almost 1/5 in adults in China. Next slide. This paper in JAMA also report a systematic review of all the cases reported, and most of them were initially from China, about 17 papers from China and one a case report from Singapore. This have more than 1,000 again participants, about 400 less than 10, and about 500 from 10 years to 19 years of age. And again, similarly, most of this cohort also had fever, cough, and fatigue, and or asymptomatic. And only one child, one infant, had pneumonia, shock, and kidney failure, but also successfully treated with supportive intensive care. And again, in this cohort of 1,000 patients, there was no death reported. Next slide. Similarly, in the US, as we see that initial infection curve rising up between February and April, these are some of the cases reported to the CDC, about 2,500 cases. And as you can see, from early March until early April, the cases has been rising up. Next one. This presentation or symptoms and signs profile in the US children was comparable to what we've seen in China. Most of the children had fever, cough, and some of them also has GI symptoms. This compared 291 pediatric case compared to more than 10,000 adults. These are just some of the cases. This is not all the cases, but these are the cases reported to the CDC from that period, from February 12th to April 2nd. And again, symptoms in pediatric were still mild compared to adults. Next. This is cohort from New York City. which surpassed Seattle. Seattle was the first focus of or epicenter of infection in adult and pediatric in the US, and then New York City surpassed Seattle, and we have a lot of cases in New York. And this is one of the cohorts from Zachariah in Columbia University and his colleagues in New York City. They described about 50 patients. Again, symptoms also mainly fever and cough, and some GI symptoms also noted. Next. The Pediatric Infectious Disease Society, which is a main infectious disease professional organization in the US. Since the start of the pandemic, we have been meeting as a national group almost weekly initially, and then maybe at least once a month. And they started a registry for all cases in pediatric cases in the US, and so far as of June 11, they update this, I think, every 3 weeks. There's more than 1,800 cases reported. This is a voluntary registry, so it doesn't include all cases in the US. But this just gives you a snapshot on how things are here. And so far, there are 6 deaths reported, but definitely this is more than this. There's a lot of other registries, and actually some of them for pediatric, they're open for international sites. So even people in Sudan, they can contribute. Next slide. Since initially, again, the symptoms with COVID-19 in pediatric were all mild and asymptomatic, but in by the end of April, some reports from North Italy, and they noticed a spike of cases with inflammatory syndrome, multisystem involvement in children who are recently exposed or had a history of COVID-19. Next slide. Interestingly, on April 7th, one of the, I think in Stanford, in California, they reported a case of a 6-month-old child who presented with fever, and during the workup for fever of unknown origin, they testing him also for COVID-19 and was positive, and then the child eventually developed a complete picture of Kawasaki disease and was treated successfully with IVIG. During our meetings that week with the Pediatric Infectious Disease Society, also the physicians from New York, they reported also they had 2 cases of Kawasaki disease during the week of April 7th, but at that time nobody was there was an association, but nobody was thinking this could be from COVID-19 until April 24th. Again, people heard reports from Italy, from rheumatologists in Italy about cases similar to Kawasaki disease in children recently exposed or had COVID-19. And then more cases emerged in UK, France, Germany, and on April 26th, the Royal College of Pediatrics and Child Health in UK published the case definition and guidance for pediatric multisystem inflammatory syndrome, and the terminology was PIMS-DS, pediatric multisystem inflammatory syndrome, temporally associated with COVID-19. And on May 4th, New York City and New York State Department of Health also they issued advisory and warning about 64 cases with MISC. Of course, in the US, we have to come up with our own name. So it's a multi-inflammatory syndrome in children. And on May 14th, the CDC followed with also an health advisory notice and case definition for MISC. And this was followed on the next day by WHO and also the European CDC, which also reported about more than 200 cases reported from different parts of Europe. Next, please. I'll talk in the next couple of slides about Kawasaki disease. Again, initially, when this syndrome emerged, it was because of the similarity to Kawasaki disease. Initially, some of the clinicians were thinking that this could be Kawasaki disease, but again, from the data collected and observations, it is now clearly different from Kawasaki disease itself. But as a refresher, Kawasaki disease is the most common primary vasculitis in children. It affects medium and small sized arteries. And for diagnosis, you have to have 5 days of fever and 4 out of the 5 criteria, which include rash and could be polymorphic rash, non-purulent conjunctivitis, mucous membrane change, and extremity change, and lymphadenopathy. Sometimes we diagnose this earlier and without the complete criteria if you have fever and evidence of aneurysm, coronary aneurysm. The main lab features for Kawasaki disease is leukocytosis and elevated neutrophil count, left shift, and also increased CRP and elevated SID rate as a marker of inflammation. So by definition for Kawasaki, you have to have fever and raised inflammatory markers. Also, you can have anemia, and thrombocytosis will follow up on the second week of illness. And you'll have hypoalbuminemia, hyponatremia, and also elevated liver enzymes, and also sterile pyuria, which usually you have to do avoid doing a cathetering to make sure you don't bypass the urethra to pick up the urethritis. The feared complication from Kawasaki, which usually increase by day 10 of illness if not treated, is mainly the coronary artery abnormalities, which can be aneurysms, infarction, thrombosis, and or occlusion at the end. Next, please. In minority of Kawasaki disease patients, also they can present with shock-like picture. We call it Kawasaki syndrome. Mainly, a lot of times it's mistaken for septic shock or toxic shock syndrome. But in kids with Kawasaki who develop, usually they will develop severe GI symptoms, more than the usual. In Kawasaki, you can have sometimes regular Kawasaki, just GI involvement as you have multisystemic involvement. You can have some diarrhea or abdominal pain, but not as severe as in when you have the Kawasaki disease shock. Also different from Kawasaki, when you have the shock, usually you'll have decreased platelets and also markedly elevated CRP. More than the regular Kawasaki, and also you have increased D-dimer, coagulopathy, hyponatremia, increased liver enzymes, and again increased lactic acid. And also with Kawasaki disease shock syndrome, you'll have increase in the troponin and increase in the CPK, with eventually decreased decreased left ventricular function, and you can also have mitral valve regurgitation. With Kawasaki disease shock syndrome, you have increased risk of aneurysms and also increased risk of treatment failure with IVIG. Next, please. This is the CDC case definition of the multi-inflammatory syndrome in children. This is mainly for epidemiological diagnostics, and it's includes severe illness that require hospitalization and at least 2 organ involvement. This can be a cardiac, renal, respiratory, hematology, GI, derm, or neuro. In addition to this, also you should have no alternative diagnosis and either a current or a recent infection from SARS-CoV-2 or exposure within the last 4 weeks prior to symptoms. For evidence of inflammation, the labs can include at least one of the following: CRP, SED-RED, fibrinogen, procalcitonin, D-dimer, ferritin, lactic acid dehydrogenase, or interleukin-6, elevated neutrophil count, reduced lymphocytes, or low albumin. Also, again, the Royal College of Physicians, they have also their case definition similar to that. In the next few slides, I will review the literature of the MISC or MESC. This literature from papers published from April 2020 to June. And if you follow the literature every day, you'll have a paper published. There have been a lot of plethora of publications so far about this diagnosis. Next slide. Again, this is the first case reported on April 7 from the US about a 6-month-old infant admitted with classic Kawasaki disease. And he was screened positive for COVID-19 because of initially presenting with fever and minimal respiratory symptoms. The patient was treated successfully with IVIG and high-dose aspirin and sent home. After completing IVIG with resolution of his symptoms. Next slide. Again, following the Italian spike in the cases, and then across Europe, in UK and France, these are the major publications. Again, in the last couple months. The first publication is from UK. That's what the first published cases, and involved 8 patients. And the main symptoms. Can you go to the next slide? The main factor in all these cases and studies across the countries was the age of the patients, were more than the typical age span we see in Kawasaki disease. As with Kawasaki disease, we usually children less than 5 years of age, and about 50% of them even less than 2 years of age. But strikingly, all patients here were older age, with the mean age of 8 in the UK cohort, and then in Italy about 7.5, and as you can see at the next one, 7.9, and then 10 years and 9 years. Also interestingly, almost all the cases, the African descent or black race was more common among all the studies. So in the UK, the first the first study, there were 6 out of the 8 patients were Black, 1 was Asian, and 1 was from the Middle East. And in Italy, all the cases were in white. And then France, also they have in the Topiana group in France, in the 3rd study, they showed that about 12 out of 21 were Black children. And again, in the last study from UK, from Whitaker and the group, they found about 38 patients were Black out of 58. And if we look at the other, can you see, go to the next slide? Sorry, can you go back? Sorry. The exposure to COVID was documented in about 50% of the time. And the symptoms mainly across all the studies, fever was present in all the participants. And here I reported only the days of fever, but all of them, they reported fever, and all of them reported also GI symptoms. Here also I reported only the diarrhea in the cohorts, but all of them, they reported some GI symptoms, either vomiting, diarrhea, abdominal pain in all the patients. So if you look at the Kawasaki disease criteria, about 50% in the Verduni in Italy, they have incomplete Kawasaki disease criteria, and about 48% in the Topiana in France, and almost all have incomplete Kawasaki disease criteria in the study from France, and about almost 80% in the study from UK in Whitaker. And all these patients has again the sign of the Kawasaki disease criteria, either mucosal erythema, changes, conjunctival injection, rashes, extremity changes, and lymphadenopathy. And again, some of them also has shock or hypotensive episodes. In the UK, the 8 patients, all of them presented with or developed shock or hypotension after admission. And in Italy, about 50% of them, and similarly in the Topiana in France. And again, you can see the next slide, please. If you look at the laboratory findings in all these cohorts, again, they reported increased white cell count, but the main important feature, if you can go to the next slide. If you look at the lymphocyte count, most of them, they reported lymphopenia, decreased lymphocyte count, and also thrombocytopenia, which is different from what we see usually in Kawasaki disease. And evidence of inflammation for the inflammatory markers, the CRP, is also markedly increased compared to Kawasaki disease cases. So all of them, they have highly elevated CRP on presentation. And also the procalcitonin was very elevated. And this is different from what we have in adult cases in COVID-19. Some they have elevated procalcitonin, but not across the board like in these cases here. Next slide. Also, interestingly, when they looked at the brain natriuretic peptide, which usually we don't obtain on a regular basis is in Kawasaki disease, unless you suspect Kawasaki disease shock. But in this syndrome, across the board, they have elevated BMP in all the studies. And also troponin, which indicates myocarditis or liver dysfunction, also has been elevated across all the studies, in addition to D-dimer, ferritin level, and interleukin 6, and also in some studied interleukin 1. The ferritin has also has high enough in some of the cases in the Verdoni group in Italy, and met criteria of macrophage activation syndrome in 5 patients. If you look at the SARS-CoV diagnostic workup, most of them they don't have a positive nasopharyngeal PCR on presentation, but almost all of the patients have positive antibody testing. So if you see the 8 cases in the UK, they all have positive antibody testing, but only 2 patients later on with repeat testing have a positive PCR. And similarly in Italy, only 2 patients have positive PCR, but about 11 have positive, 8 has positive antibody testing out of the 10. And similarly, if you look at the study from Beldager and group, they have about 86% positive for antibody testing. And similarly, in Whitaker group, about 83% they have positive antibody testing. There was no evidence of concurrent other infections with all these patients. Only in the UK study, the first one, they reported an adenovirus and enterovirus concurrent infection with this syndrome. And all of them, there is no evidence of bacterial superinfection or fungal superinfection with this. Next. Next. If you look at the treatments, management and outcomes. Next slide. Actually, in the top, if you look at the serous effusions, just an indication of the systemic inflammation. Most of them, they have also effusions, and in all the 8 patients in the UK, they have either pleural effusion, pericardial, or acidic effusion. And some of the other case series also has similar findings. But most of the cases, they reported cardiac involvement with left ventricular dysfunction, mitral valve regurgitation, and coronary artery abnormalities. And if you look at the treatment of choice, most of them, they responded very well to IVIG across the board with high dose IVIG 2 gram per kilo. And some of them also, and actually most of them also, in addition to the IVIG, they gave steroids and aspirin, and some of them also gave steroids, systemic steroids. The immune modulators, infliximab and IL-1 inhibitor and IL-6 inhibitor, tocilizumab, were used very sparingly. One patient, they used anakinra in the French study, and there is no use of IL-6 inhibitors reported in these cohorts. Again, because of the cardiac involvement, some of the patients also received epinephrine or milrinone or dopamine to treat their shock. Although there is no respiratory failure reported in these cases, but some of them required mechanical ventilation to support as support. There was only 2 reported death in all these studies. One from UK, sorry, 2 from UK from the RIFGEN study, the first study, and also the last study. But otherwise, most of these patients responded very well to IVIG, aspirin, steroids, and supportive critical care. And still, there is a lot of other publications coming again. As I said, on a weekly basis, there is another study from France just published recently. It didn't include, they included 20 patients with similar findings, and also a good response to IVIG and steroids and aspirin. Next slide. Again, the association with SARS-CoV-2 virus is clearly evident from all these studies, although a causal link is still have to be proved, and pathogenesis studies still in the works. Next slide. This is Italian study in the literature review table by Verdoni and his group. This study was done in Bergamo city in Italy, in one of the pediatric hospitals. They noticed again a lot of cases of Kawasaki disease syndrome in the recent month, and they compared the incidence to the previous 5 years of Kawasaki disease, like or Kawasaki disease to this multi-inflammatory syndrome we've seen. And if you see the cases presented in the stars denotes each case they report. So on the graph on your right side, you can see the cases of COVID-19 starting from February 1st with a lot of cases, and as the cases subsided, then they started to see the multi-inflammatory syndrome cases. Next, please. This study was also published from France from a nationwide surveillance. They reported about 156 cases in about 2 weeks period. Again, with the median age of 8, similar to all the other studies. And this just confirms again the emergence of the PIMS or MISC associated with the SARS-CoV-2. From their study, they estimated about the risk. They could not for sure say what the risk is, but they estimated if about 5% of the children in France had COVID-19, then the risk for this new syndrome would be about 2 per, or less than 2 per 10,000 child in France. Next slide. This is the same study, just showing where the COVID-19 cases and also the new syndrome emerging in the same areas of COVID-19 infection. Next. And this again also showed similar picture of hospitalization. As you can see, the COVID-19 hospitalization rate decreased. This is in the orange curve. As the cases decline, then you see increased incidence of the MICC, MIS-C or PIMS, the new syndrome. You can see in the confirmed cases in the dark green bars, and probable cases in the light in the other green colors. So again, this is this observation led to suggestion that this syndrome is a post-inflammatory syndrome rather than caused by direct effect from the virus itself or from the virus invasion. Next, please. Another evidence also from New York City. This is the SARS-CoV-2 or COVID-19 positive cases in the blue bars, starting from mid-March all the way to mid-May. And then you see the start of reporting of the cases of MIS-C started from mid-April. And this is clearly showed that about 4 weeks after patients get exposed or infected with COVID-19, then they develop this new syndrome. Next, please. In the next couple of slides, I'll be talking about comparing the COVID MIC shock and Kawasaki disease shock. Next. So the main difference we can see is in the MIS-C shock. The children age is more than 5 years of age, compared to Kawasaki disease shock, which usually in Kawasaki disease in general, the incidence is less than 5 years of age in about 80% of the time. And in children less than 2 years of age, most of the cases, about even 50% is in less than 2 years of age. So clearly, the older age stand out as a big difference between the MSC shock and the Kawasaki disease shock. And the next thing is MSC shock or cases has been predominantly in the African descent population. This was clear in the first study from Europe, from UK. 6 out of the 8 patients were from African descent, Afro-Caribbean descent. And again, in New York, also most of the cases are in Black African or colored children. The other striking features and clinical presentation is the severe abdominal pain in the MSC shock compared to Kawasaki disease shock. And in some cases, there is some children actually they end up undergoing appendicitis or have surgical abdomen. And this is mainly people think because of the enteritis associated with this virus infection. Another different laboratory features is lymphopenia is present in MSC shock, and it's not a feature in Kawasaki disease shock. Thrombocytopenia also is present across the board in MSC shock, and in Kawasaki disease shock is present, but as not as severe as in COVID-19 shock. Also, elevated BNP and troponin is universal in all MSC shock patients on presentation. In Kawasaki disease shock, it's elevated, but again, the limitation is we usually don't obtain troponin or BNP in all Kawasaki disease patients unless there is cardiac involvement or aneurysm documented, but it's not a routine lab. Usually we obtain in Kawasaki disease patients. In MCC shock, again, most of the children has myocarditis and myocardial dysfunction. In Kawasaki disease shock, the rate of aneurysm is definitely higher, and compared to Kawasaki disease, and among 25 to 60% of the time, you can have coronary artery aneurysms. Next, please. This is again from the Verdoni, the Italian cohort study of the 10 patients. They compared again, as you can see, in group 2 is the COVID-19 SARS-CoV patients, and group 1 is the Kawasaki disease patients in the previous 5 years. And again, it's clearly that the age is a big difference in the two groups, with 7.5 years mean age in the COVID-19 group compared to 3 years in the Kawasaki disease. And in their study, they noticed about 30-fold increase in the incidence of Kawasaki disease-like syndrome compared to the previous 5 years, with 0.3 incidents per month in the first group, and that's increased to 10 cases over a period of month. And actually, I believe all the 10 cases were reported over a period of 10 days. Yeah, of 10 days in mid-April. Next, please. This again, the same group in Italy. They compared again the two groups. This in terms of the laboratory findings. Again, as you can see, the CRP is elevated in the two groups, but was more elevated in the second group. And the neutrophils also more increased in the COVID-19 group, with also marked lymphopenia in the COVID-19 group. And clearly also you can see that thrombocytopenia is more predominant in the COVID-19 group. And similarly also the ferritin level, just tell you how marked the inflammation is in the COVID-19 group. Next. This merely just to show that the response to treatment is universally good across the two groups responding to the IVIG, aspirin, and steroids. Next group. This just our summary from all the studies showing that for evaluation of these patients, I would start with obtaining a CBC with DEF. This will clearly show you the lymphopenia and the thrombocytopenia, and also document the inflammatory markers. CRP and SID rate will be your initial step, and if you have procalcitonin in your institute, also that will help. Electrolytes, renal function, and liver enzymes, all are basic labs to obtain, and then I would follow that with PT, INR, fibrinogen, D-dimer, CK, and then ferritin, LDH, cytokine panel if available, and BMP or BRO-PMB, blood gas, lactate, and urinalysis. And I would obtain microbiology labs, blood culture, and urine and other cultures as indicated. Viral testing also, if available, will help rule out other infections like adenovirus infection or enterovirus infection or EBV. This all can have similar severe presentation at times. And I would obtain SARS-CoV-2 nasopharyngeal PCR, and follow that with antibody testing IgG, and later on also you can send this to PCR if there is GI symptoms, or if this can be sent from your institute. The radiological studies will definitely obtain an echo and EKG on presentation, and then a chest X-ray and CT if indicated, and also abdominal imaging as indicated. Next slide. The management of MISC is mainly supportive critical care, and treated as you need to establish your IV axis and start fluids, treat any shock, and again, just supportive cardiac and critical care. You can use epi or nor-epi or other inotropes as indicated, and then mechanical ventilation and ECMO if needed. ECMO has been used in only few cases in the previous cohorts. Empiric broad-spectrum antibiotic is initiated in most of these patients, and you can easily de-escalate or discontinue when your cultures are negative. The mainstay for therapy of these patients is the IVIG, just like Kawasaki disease, 2 grams per kilo over 8 to 12 hours, and follow that with aspirin, and in some cases steroids if there's no response, and in a very few cases they use storm with these patients. Antiviral therapy like remdesivir is not indicated in these cases, as again, all the evidence point to that this syndrome is post-inflammatory syndrome and not caused by actual viral infection itself. And most of all these cases usually they're treated with a multidisciplinary team, ICU, the cornerstone, and with consults to the several service ID, rheumatology, and cardiology and hematology. Next slide. I think this is my end for my slides. This is to summarize. Kawasaki-like multisystem inflammatory syndrome in children has been emerging and recognized recently as a clear association with recent SARS-CoV-2 infection, occurring about 4 weeks from exposure or acute infection. Almost all the cases reported so far from Europe and North America, no cases reported from China or Asia. And again, likely to represent a COVID-19 post-infectious complication. And the main difference from classic Kawasaki disease is an older age, more than 5 years, and more common among African ancestry. And at this point, it's not clear it is due to a genetic predisposing factor or just because of high incidence in these communities. Again, the presenting features, acute GI symptoms in almost all of the patients, fever, lymphopenia, and thrombocytopenia. And also majority has hemodynamic instability, myocarditis, and myocardial dysfunction. And like Kawasaki disease, they all respond very well to IVIG, in addition to systemic steroids if needed. There is a lot of questions still need to be answered, and still we don't know if this syndrome is going to be only excluded to children like most of the Kawasaki disease cases, or also will spill to adult population. So time will tell. And again, also the association with this syndrome with Black, African, or Afro-Caribbean descent warrants us to continue to observe this in Africa as the cases continue of COVID-19 continue in Africa, and to look for any cases emerging. Next, please. This is just some resources about COVID-19. I know there's a lot of literature going on, but if you need a quick pediatric resources, I would highly recommend PIDS and Red Book online also. Up to date, still they have free access to COVID-19, and CHOP, Children's Hospital Philadelphia, they have clinical pathways for COVID-19 and also for a lot of other pediatric clinical pathways, so you can refer to that. Next, please. This is the end of my talk, and I know mainly most of their attendees from University of Jazeera. This is a picture of my backyard, and as you can see, this is a cornfield. I'm working in SIU, Southern Illinois University, which is serve the central and south Illinois, which is mainly rural area. And the university, actually, the medical school was established in the 1970s, just like University of Jazeera, to serve the rural population here. And since their establishment, they have been also an advocate for problem-based learning. Actually, they are the first medical school to start that in the 70s. And also they started the simulated patient in clinical exams. So they are I'm proud to be here, and they are leader in education and innovation, and looking forward to more work and collaboration with you guys. And I'm ready for any questions. Thank you very much.
We don't have any questions, Dr.
Thank you very much.